I'll just quickly go through most of the points she has developed. The other names for daycare surgery is ambulatory, daycare, same-day surgery, and all the come and go surgery, all fancy names. And so the patient is operated on a planned manner on a non-residential basis. They are not admitted for investigation and other purposes. They are all done as outpatient, and patient just occupies the bed in the ward for the purpose of surgery and then goes back the same day. Allows the patient to return home on the same day that the surgical procedure is performed. So what made this possible, made daycare surgery possible, is the availability of all the recent drugs and the some of the procedures which do not require prolonged hospitalization. That is another reason this concept of daycare surgery was brought out. And prolonged stay caused other nosocomial and other infections the patient can contract from the hospital from other patients. So daycare surgery prevented all these things. So these are the things which led to the concept of this. So what are the advantages? It reduces, first of all, the medical cost. You don't have to pay for the room rent and other things unnecessarily. And it makes the availability of beds for other major patients or other serious illness patients who can be admitted and treated. And it covers the business and personal better comfort, and they can get back. Only those who have had patients admitted in the hospital know the difficulty. Someone has to be there to sign the consent form, make sure that the patient informations are given periodically to them. So it disrupts the normal life at home when a patient in your family gets admitted in a hospital. So all these things are very much reduced when you do daycare procedure, and the hospital-acquired infections are prevented, and reduce separation and anxiety problem in children especially, and faster recovery, more better discharge and pain relief if the patient is given good analgesia, and less preoperative testing and postoperative medications. So Miller, if you read the chapter on daycare anesthesia, it said no extensive investigations is required for daycare procedure, especially if it is a very minor category like cataract procedures or ophthalmic procedures or ENT procedures. No need for any extensive investigations. But majority of the hospitals nowadays, what they commercial basis, they give the surgery pack, which will include right from CBC to echocardiogram and even MRI and CT scan, which are all not necessary. Okay, so that is a money-making thing by the hospital, but the real concept is not necessary for extensive investigation. And all these are the examples of surgeries which we mentioned correctly: gynecology, plastic surgery, ENT, orthopedic, etc. And the facilities and design. This is what is I told. There are 4 models. This is described in Miller again. The hospital integrated, where the daycare procedure is shared along with the other facilities that are available in the major hospital. Then hospital self-contained, functionally and structurally they separate from the inpatient facilities with their own reception, admission area, operating room, recovery area, etc. So this is a separate block which will be there, where there is no permanent inpatient admission here. Then there is a freestanding, where complete separation from the inpatient and emergency, office-based, associated with the physician's office for the convenience of the patient and healthcare. And this is the design that you have to have. This will be the entrance, that the waiting area, changing rooms. Then patient goes to preparation holding, operating room. From there, you can go to general recovery or step down and go back and go home. So this is the whole cycle, how it should be designed. And they should have these facilities: an anesthetic room, an operating theater, and a fully equipped recovery room. These are the 3 important things that you should have. You can see this is the operating room, this is the recovery room, and there is a anesthetic room incorporated in the operating room itself. and there will be a equipment. All these equipment should be available, and all these monitors should be available for daycare. And after the facility design, you should talk about the patient selection criteria, which you correctly mentioned: the surgical factors, medical factors, and social factors, which are the things which decide how to select the patient. And age-wise, physiological status and fitness should be considered rather than arbitrary age limit. So, patient who is more than 80 without much morbidities can be taken up. But older patients have reduced post-op cognition. That is the only problem that we have to think about. Similarly, newborn or premature babies have the problem of post-op apnea, which I told earlier. So these babies should not be taken up as a daycare procedure because they require, as I said earlier, 24 to 48 hours of continuous oxygen saturation monitoring to prevent this post-op apnea problem. So you must choose the correct age patient. And the ASA, earlier they were taking only 1 and 2, but now even 3 with comorbidities under good control, you can definitely take them, which includes diabetes, hypertension, asthma, epilepsy also. What are the contraindications for daycare? Cardiovascularly, these are all the recent MI, hypertension, angina, arrhythmias, acute respiratory infection, asthma requiring everyday beta-2 agonist or steroids, metabolic problems like insulin-dependent diabetes, renal failure, alcoholism, and neurological patients who are on chronic steroid therapy, MAO inhibitor therapy, anticoagulant. These are all patients who have higher risk. So you have to have a facility for monitoring their drug intake in the post-op, either by communication or by home visits. Then only they can be taken up for surgery. And coming to the pre-op assessment, 3 primary components of pre-op assessment are history, physical examination, and laboratory testing. And you can see the laboratory testing has only 8% here. That means you do very minimal testing for daycare procedure. You depend more on the history and physical examination of the patient. Okay? All paperwork, consent form, everything should be done in the pre-op phase itself. And then you decide the date of surgery, ask the patient to come on the day of surgery, and you get a written and verbal instructions regarding arrival time, place, fasting instructions, information concerning the post-op course. Everything should be explained to the patient, and they should be encouraged to continue all chronic medications and oral medications, which can be taken in the morning, like thyroid supplementation or the antacids or antihypertensives. They can be taken with sips of water up to 30 minutes of surgery, and they can be given special instructions because like anticoagulants and other things which have to be stopped should be very clearly instructed to the patient. And pre-medication, if the patient is very anxious, you give usually an anxiolytic like diazepam or oral midazolam, but otherwise normally no and pre-medication is prescribed. Everything can be given in the theater either by oral or in IV route. But oral antiemetic pre-medication can be definitely given in patients who have the risk of post-op nausea and vomiting. And you normally use multiple drugs, as you rightly said, not to depend only on one drug. And if the patient has features of GERD, then you have to give a head-up tilt during positioning, during induction in the general anesthesia. And the anesthetic technique, all anesthetic techniques have been used right from GA to monitored anesthesia care and sedation. And the drug of choice for general anesthesia is propofol, because that is the drug with which the patient has no hangover effect and the clear recovery emergence will happen. Inhalation agents, either sevoflurane or desflurane will be the agent of choice. Nitrous oxide increases the risk of post-op nausea and vomiting. So you can try to avoid that and use these 2 agents alone. And TCA and neuromuscular blocking drugs are used and very commonly used because the recovery time is very short, and neuromuscular blocking agents, depending upon the surgical requirement, can be used, and the drugs of choice are cisatracurium or nevoflurane, which are easily reversed or even get eliminated by themselves. And coming to regional anesthesia in daycare surgery, spinal anesthesia was initially thought not suitable, but nowadays with the short-acting drugs like chloroprocaine and the use of very fine needles like 28 or 30 gauge needles to prevent post-op dural puncture headache (PDPH). Now this has become a routine. Subarachnoid block is considered an ideal technique because it is technically easy compared to epidural or caudal blockade. And other techniques like intravenous regional anesthesia, peripheral nerve blocks, and local infiltration, all these things have the advantage of discharging the patient within 1 or 2 hours of the anesthesia and surgery. So any limb procedure done under Bayer block or the plexus block, patient can go home within 2 to 3 hours once the motor effect is gone. And with the epidural, there is an advantage that you can send the patient with the epidural catheter also with a very low concentration local anesthetic to produce post-op pain relief even at home. So that is an advantage for the epidural. And factors which can cause delayed discharge are female gender, advanced age, longer operations, large fluid or bone blood loss, and very need for very high doses of opioids, and uh, unexpected higher doses of neuromuscular blocking agent use, persistent post-op pain and nausea, vomiting, and motor blockade not relieved and after spinal anesthesia are all causes which can delay the discharge. And recovery, as we said, there can be first stage, second stage, or as we mentioned, early, middle, and late stages. So first stage is where patient has completely, especially after a general anesthesia, patient should be able to have a complete good cough reflex, swallowing reflex, and he should be able to protect his airway, and he should be responding to commands. And of course, under regional anesthesia, they will be completely awake, so they can bypass the post-recovery area and go straight to the discharge area. And the second stage is the patient enters, waits there in the recovery area for some time, and then goes to the discharge area. And late recovery is a complete return to normal physiological activity. That will happen not immediately, but it may take weeks or months, and it is going to happen at home. And these are all the vital signs which are given the values of 201 based on the percentage that is there. Then ambulation, whether the patient have a steady gait with assistance, no ambulation, nausea, vomiting, minimal, moderate, severe, pain, minimal, moderate, severe, and surgical bleeding, minimal, moderate, and severe. All these 5 things are given marks, and patient who has highest mark here is a good candidate for discharge. So if he has 9 out of 10, he can be discharged easily. But if he has got 3 or 4, he has to remain in the hospital. And guidelines for safe discharge are stable vital signs, return to baseline orientation, ambulation without dizziness, minimal pain and minimal nausea, vomiting, minimal bleeding. All these things are the guidelines that we have seen. And patients who have come as an individual without attender should not be allowed to drive on their own if they have undergone general anesthesia. But if it is a plexus block or a local infiltration, they can still go on, and they should not be allowed to operate any machines or take any important decisions, and abstain from alcohol for at least 24 hours. Patients should be advised that may experience slight pain, headache, all these things should be explained to them and not to worry about it unless it is very severe. And there should be a responsible adult to look after them at home, and staff members should have the telephone number of the patient and call them next day to assess the progress and recovery. This will help to audit your results. So you must be in contact with the patient to find out what type of reaction or the progress the patient made. So the audits and evaluations of unexplained admissions may help to highlight areas of improvement in services. So from this follow-up procedures, you can improve your services. And these are the barriers, she said, why daycare is not developing as commonly as we expect is all these factors which you mentioned, which is given in the tutorial of the week, World Federation of Anesthesia, and all of you can get that reference. So that is the thing on